Good evening, ladies and gentlemen. You're welcome to another series of our clinical educative forum on the AFRH, Association for Fertility and Reproductive Health. My name is Mrs. Bamil Abdullahi Saleh, a clinical psychologist, and co-moderating with me today is Mrs. Inipi Uja Samuel, a certified embryologist. Mrs. Inipi, can we see your face? Say hello to the team. Mrs. Inipi, can you unmute and let's see you? If not, maybe later she'll join us. Yes, so you are welcome to today's series. Our presenter for today is Dr. Chichi. That's Dr. Chiemelie Onwudiegwu. Ma, are you there? Can we see your face?
Good evening. Good evening, everyone.
Good evening. Thank you for joining us. You look sharp this evening.
Thank you.
Yes, ma'am. All right. So before we start, I would like to announce that this is the last of the series for this year, of the clinical series for this year. And I want to congratulate AFRH for a wonderful job done from February till date on this series. It has been very educative and very impactful. We have learned a lot from all units, all aspects of ART. Um, that said, I would want us to go right ahead with the presentations. Are you ready, Doctor? Let me introduce you properly. Mrs. Inikwe, are you with us now? All right, so Dr. Chichi is an, an obstetrician and gynecologist that works at the George's Memorial Medical Center in Lekki, Lagos. She's certified by the Western African College of Surgeons and holds a membership in the prestigious professional organizations such as the Society of Obs and Gynae of Nigeria, SOGON, and the Association for Fertility and Reproductive Health. She's through her continued education and active through her continued education and active participation in professional associations, she's dedicated to providing compassionate care. The beautiful Dr. Chichi remains at the forefront of advancing women's health and reproductive rights in Nigeria and beyond. So can we use any emoji you prefer, your favorite emoji, to please welcome Dr. Chichi to give her presentation? Yes, thank you, ma'am. So
Thank,
over to you.
thank you so much. Good
You're
evening,
welcome.
everyone. I hope you can all hear me.
Yes, I see the
Hello?
emojis flying. So yes, I believe we can hear you, ma.
Okay.
Go ahead. Yes.
Okay, I hope we've had a great day. So, today I'll be talking about menstrual disorders, evaluation, and treatment. And I'll be using the following outline. So, sorry, please pardon me if my voice isn't very clear. I have a cold. Okay, so this is the outline I'll be using for my presentation. Okay, and then let's do a quick overview of the menstrual cycle. So we know that menstruation is the monthly flow of blood from the uterus through the cervix and out through the vagina. And we know that it occurs between puberty and menopause. Normal length is 21 to 35 days, but most average is 28 days. And duration of bleed is about 2 to 7 days, but most women bleed for 3 to 5 days. And is regulated by the hypothalamo pituitary ovarian axis. And we know that there are phases to the menstrual cycle. You have the follicular phase, ovulation, and then the luteal phase. And the key hormones that regulate the menstrual cycle are the gonadotropin releasing hormone, which is produced by the thalamus. Then follicle stimulating hormone and luteinizing hormone, is produced by the pituitary. And then the ovaries produce estrogen and progesterone. So this is a graphical representation of what I have just described. Let's do a little bit of anatomy. So the cervix, it's the lower portion of the uterus, and it connects the uterus to the vagina. It allows menstrual blood to drain. And we know that the fallopian tubes connect the uterus and the ovaries. And it is through this that the eggs are taken to the uterus. The ovaries, they contain follicles, which are fluid sacs that contain the eggs. The uterus is a hollow muscular organ. It is located between the bladder and the rectum. It has an inner layer that's called the endometrium, and this usually will thicken and become engorged. The blood vessels become engorged, getting ready, for pregnancy, to help nourish the growing fetus. However, if pregnancy does not occur in the cycle, this endometrium is shed, and then menstruation occurs, and then the menstruum will flow out from the cervix and the vagina. So I said earlier that the menstrual cycle is regulated by hormones and is divided into phases. So we'll talk about the phases now. The first one, we'll talk about the follicular or proliferative phase, and it begins with the menstrual bleed. And here, estrogen and progesterone are at their lowest levels. FSH levels start to rise to stimulate maturity of the follicles. The ovaries then start to produce estrogen, but at this time, progesterone levels are still low. This estrogen release signals that the egg is mature and is ready for ovulation. At the same time, the endometrium also thickens to prepare for implantation. So at ovulation, this begins with the surge in LH and FSH, and this occurs 12 to 36 hours after the LH surge. The follicle ruptures and then releases the eggs. These eggs are then picked up by the fallopian tube and then transported to the uterus. Then we have the luteal phase, which is also called the secretory phase. At this time, the ruptured follicle forms the corpus luteum. And it's the corpus luteum that produces progesterone. So with progesterone and estrogen now, the uterine lining, it thickens. Then you have stimulating blood vessels in preparation for implantation. If fertilization occurs, the embryo implants in the uterus and then pregnancy begins. If fertilization does not occur, of course, the endometrium sloughs off and the corpus luteum also degenerates. And at this time, estrogen levels and progesterone levels drop off, then the sloughing off, and then the menstrual cycle starts all over again. So it's a continuous process. And this is a graphical representation of what I just described. You can see how the FSH levels, CLH when it surges, ovulation occurs, and then all that. So I'm going to talk about that you can have the times where there's some things that are normal, they're not disorders, they're normal in the period. So you can have normal absence of periods that can occur in pregnancy, in breastfeeding, and in menopause. So now let's go to the disorders proper. So when you say menstrual disorders, what do we mean? We mean that there are abnormalities in cycle length, the flow, frequency, or associated symptoms, and this include irregular periods, heavy, painful, absent, or unpredictable periods. Now we have amenorrhea, and amenorrhea is can be defined as primary or secondary, and we say that primary amenorrhea occurs when a girl who has not started menstruating by the age of 15. However, girls who do not show any sign of sexual development, that is no breasts, no pubic hair, by the age of 13 should be evaluated by a doctor. And we know that secondary amenorrhea is cessation of menses in a woman who has previously menstruated. If the period has ceased for 3 cycles consecutively, then you say that that is secondary amenorrhea. Then abnormal uterine bleeding, you have different types. You have menorrhagia, meaning that the bleeding is very heavy or the days are prolonged. And when we say heavy, we mean more than 80 mils during that period. Then polymenorrhea is when you have too frequent menstruation, and that is the interval is less than 21 days. Metorrhagia is intermenstrual bleeding. This is irregular bleeding during the cycle, and menometorrhagia is when this irregular bleeding is very heavy. We have oligomenorrhea, which is that the person doesn't bleed often. It's infrequent bleeding, usually greater than 35 days as the interval. And hypomenorrhea means that the volume of the flow is reduced when it's less than 20 mils. Usually, you say that there is hypomenorrhea. And then we have dysfunctional uterine bleeding. It's an old term, but it is usually said that this is bleeding that's not due to either structural problems, pregnancy, or what do you call it? Medical conditions. So we have dysmenorrhea. This is pain during menstruation, and it can be primary or secondary. Primary dysmenorrhea is usually due to uterine contractions, and secondary is when there's a condition, a pathology or something that is causing the dysmenorrhea. Then we have the premenstrual syndrome and premenstrual dysphoric syndrome. Premenstrual syndrome is usually a set of physical, emotional, and behavioral symptoms that occur during the last week of the luteal phase. And that is the week before menstruation. And these symptoms usually will not start until 7 to 10 days before the period and will typically resolve within 4 days after bleeding has begun. Many women who have premenstrual syndrome, they have symptoms at any time during their reproductive years. So they might not have it from the beginning and then begin to have it and then can stop. But it usually occurs when they're in their late 20s to early 40s. Once the symptoms are established, the symptoms they tend to be fairly constant until menopause, although they can vary from cycle to cycle. So it's common among adolescent and reproductive age women, and 75% of women experience dysmenorrhea. Abnormal bleeding affects about 10 to 30% of reproductive age women. So what's the etiology? HPO axis dysfunction, outflow tract abnormalities, structural causes like fibroids, polyps, adenomyosis, endocrine causes like PCS, thyroid disease, hyperprolactinemia, coagulopathies, and systemic illnesses, medication. Excuse me. Okay. So amenorrhea, why? So one of the first things would be the hypothalamic defects. And when this occurs, it's called hypogonadotropic hypogonadism. And one of the things that can cause that is the defects of GnRH transport. So GnRH is produced but can be transported. And this can occur from pituitary stalk compression or destruction of the arcuate nucleus. And this can be because of a tumor or when there's irradiation or if there's trauma. Then there's defect of GnRH pulse production, and this is usually because it's seen in pubertal girls when there's chronic stress, extreme weight loss, vigorous athletic exertion. Then congenital GnRH deficiency. If it occurs alone, it's called idiopathic hypogonadotropic hypogonadism. But if that patient has anosmia, meaning can't smell, then it's called Kallman's syndrome. We also have pituitary defects. You have the congenital pituitary dysfunction, and then we can have acquired pituitary dysfunction. And this can occur in Sheehan syndrome. And we know Sheehan syndrome is pituitary necrosis following severe postpartum hemorrhage. Then it can occur following surgical ablation, irradiation, or if there is a pituitary adenoma. And then we have ovarian and ovulatory dysfunction. So the first is ovarian dysgenesis, what we call hypogonadotropic hypogonadism, because in this one, the gonadotropins are high, but there's no estrogen is low because the ovary isn't working. So the most common cause of primary amenorrhea is usually ovarian dysgenesis, and is usually associated with sex chromosomal abnormalities, premature ovarian failure, then steroid enzyme defects. For steroid enzyme defects, they usually can produce estradiol, and therefore they do not menstruate. Excuse me. Then there's ovarian resistance, what we call Savage syndrome. And this is because there's a defect in the cell receptor mechanism, a defect in the cell receptor. And that's why the ovaries do not respond to estrogen. And of course, polycystic ovarian syndrome. Now, outflow tract abnormalities have Mullerian dysgenesis, and this is usually characterized by congenital abscess of the uterus and the upper two-thirds of the vagina. Then we have vaginal agenesis, then transverse vaginal septum, and this is from failure of fusion of the Mullerian and urogenital sinus. Then we have imperforate hymen and Asherman syndrome. We know what Asherman syndrome is. This is when you have uterine synechia from overzealous curettage. But the other causes of uterine synechia includes tuberculosis, infections, and things like that. So for menorrhagia, what can be the cause? We have hormonal imbalance, anovulation, uterine fibroids, endometrial polyps, endometriosis, and adenomyosis. We have drugs, and contraceptives, bleeding disorders, cancers, infection. Now, let's talk about dysmenorrhea. So, like I said before, I said PAM is caused by the contraction of the lining of the uterus, and this is usually it's caused by prostaglandins, and prostaglandins have been found to be higher in women who have dysmenorrhea. Leukotrienes also have been implicated because it's been found that they have higher leukotrienes. Then we have the secondary dysmenorrhea, which is usually due to a pathology. And you have things like endometriosis, adenomyosis, uterine fibroids, pelvic inflammatory diseases, infections, tumors, and polyps causing them. Then we have premenstrual syndrome. One of the causes has been proposed is hormone fluctuations, and this is due to progesterone estrogen imbalance. And this imbalance causes an increase in production of aldosterone, which will cause bloating and fluid retention. Then genetics, we found that if if you have family members who have maybe a sister or a mom that has PMS, then you're more likely to have it. Then changes in chemicals in the brain found out that serotonin is usually low in these women. And also with people who have calcium or magnesium deficiency, they're more likely to have a menstrual syndrome. So what are the risk factors? We have adolescents, pre perimenopause, obesity or underweight, chronic stress, endocrine disorders, medications, and if you have a family history. So what are the features? We said irregular cycles, so the patient can complain of maybe intermenstrual bleeding, a heavy bleeding, shortened cycles, all the things we have talked about before. Then severe pelvic pain might be pelvic pain radiating to the back, to the legs. Some people have other symptoms like diarrhea when they have their pains, their mood disturbances. I have talked about anxiety, irritability, loss of libido, low appetite or increased appetite, and then infertility. So evaluation, the first thing is it's a detailed history. Of course, we want to know what symptoms they have, when they started, and the menstrual diary is very important here. How was the person when they started menstruating? What is their record over a period of time, 3 to 6 months? You want to know um, what's the flow, how many pads they use. You want a detailed menstrual history. You also want to know the symptoms. When did they start? Have they progressed? Is it better? You'll also want to ask about the etiology of these symptoms and, of course, complications and treatments they've received so far. Then physical examination is very important to examine properly because there are also different things that can be responsible. You're checking, things as simple as is there a goiter there at the eyes? Is there ptosis? Because all this can be a pointer to thyroid dysfunction. Is there hirsutism, acne? So a thorough physical examination. And of course, your pelvic examination, you're checking different things. Is there a mass? Are you feel any nodularity for endometriosis? All those things. Each that you're going to be doing a vaginal swab, pap smear. And pregnancy test is important, especially when you're talking about abnormal uterine bleeding. Have to rule out pregnancy. Then, of course, all the other things you're doing, full blood count, hair function test, prolactin levels in case of hyperprolactinemia, LHFSH, coagulation profile, karyotyping, pelvic ultrasound hysteroscopy, endometrial biopsy when indicated. So, evaluation for primary amenorrhea. After your history and your physical examination, you're looking at this patient. Are there secondary sexual characteristics? If there's not there, then you want to measure the FSH and LH levels. If FSH and LH are less than 5, then you know that this is either a pituitary or a hypothalamus problem. So it's hypogonadotropic hypogonadism. If FSH is greater than 20 in international units and LH is greater than 40, then you know that this is probably a problem of the gonads. So it's hypergonadotropic hypogonadism. If you do a karyotype at this point, is this person really female? If it's XX, then that means that it's just gonadal failure. If the person has secondary sexual characteristics, then you want to be doing an ultrasound. Is the uterus present or absent? If it's absent, then you want to do your karyotype analysis. Is this XY or XX? Is this male or female? If it's XY, then that's androgen insensitivity syndrome. If it's XX, then that's Mullerian agenesis. And androgen sensitivity syndrome, I talked about it before. I said it's a rare condition in which a genetic male is unable to respond to male hormones and leads to either partial or complete failure of male sexual development and is caused by a mutation in the androgen receptor gene on chromosome X. So for Mullerian agenesis, as said before, it's a condition where the uterus and sometimes part of the vagina does not develop. It's usually called Mayer-Rokitansky-Kosa-Hossa syndrome. Now, if the uterus is present and is normal, then it might be an outflow obstruction. If it is, that's either imperforate hymen or transvaginal septum. If there's no outflow obstruction, then we should evaluate as secondary amenorrhea. So for evaluation of secondary amenorrhea, after you've done your pregnancy test, you're sure it's not pregnancy, there's no thyroid dysfunction, prolactin levels are normal, then you go ahead and do your progesterone challenge tests, which usually we use Primolut, given 10 milligrams of it for 7 to 10 days, and wait for a withdrawal bleed. If there's a withdrawal bleed, then they're probably anovulatory cycles, and you're thinking about polycystic ovarian syndrome. If there's no bleed, then we'll do the estrogen progesterone challenge test. Usually, we commonly use the oral contraceptive pills because that means that there's been no estrogen priming. If there's a bleed, then check the FSH levels. If FSH is greater than 40, then we're either dealing with menopause or premature ovarian failure. If SFSH is less than 5, then it might be due to stress, chronic illness, can be to vigorous exercise, a tumor, Sheehan syndrome. Now, if there is no withdrawal bleed after the estrogen progesterone challenge test, then we should be thinking about outflow obstruction, Asherman syndrome. Now, evaluation of the abnormal uterine bleeding. So after taking, of course, our history and our examination, we've done our blood test. We've done a pelvic ultrasound. Is there a gynecologic problem? If there is, if there's no gynecological problem, we should be thinking about other things like thyroid disorders, coagulopathy, rectal bleeding. Some people don't know the difference between vaginal and other bleeding, so rectal bleeding. And then if it's a gynecological problem, should be checking do hysteroscopy. Sometimes you need to do an endometrial biopsy. If there's a pelvic pathology, then so I'm talking about different things to do: uterine artery embolization, medical therapy, hysterectomy. If it's just a dysfunctional bleeding, then medical therapy using the intrauterine device. You can do endometrial ablation or sometimes hysterectomy if it's still not the bleeding is still not abating. Then evolution of dysmenorrhea. So would usually just dysmenorrhea, and especially if it's primary, we'll try the non-steroidal anti-inflammatory drugs or the oral contraceptives. Now, if it's secondary, once you take care of whatever the problems are, if it's pelvic inflammatory disease, you treat. If it is fibroids, and whatever it is, if you treat, then the pain would stop. But if it's primary and you've given your NSAIDs or oral contraceptives and symptoms are relieved, then just continue therapy and then reassess in 6 months. If there's no relief, then you do your testing, check for infections, gonorrhea, chlamydia, and things like that. If it's positive, then treat for pelvic inflammatory disease. If it's not, you're doing your ultrasound to assess and check if there's any pathology. If there is, you treat. If there is none, then you do further testing, hysteroscopies, laparoscopy. If there's any finding, you treat. If not, so this is a stepwise um, method to evaluate for dysmenorrhea. And then management of PMS, as your premenstrual syndrome. Um, so you want to, of course, you want them to keep a diary of what their symptoms are, when it starts, when it ends. And then we'll talk about lifestyle modification, what to do, how to change, quit smoking, exercise regularly, eat well. And then cognitive behavioral therapy. And like I said, some of them, they say they lack some, they have some deficiencies, calcium, vitamin D, magnesium. So that can be given to them. Then we have the hormonal treatments, estrogen, danazol, GnRH. And in some patients, they might need to have the selective serotonin reuptake inhibitors. Those ones have been shown to help, especially when they have um, depression, mood changes, and then rarely you might need to do oophorectomy, hysterectomy, and bilateral salpingo-oophorectomy for these patients. So treatment generally depends on the costs and the severity, and we should consider the fertility goals and the preferences of the patient. And lifestyle modifications is very important, especially in cases like amenorrhea, PMS. Very important because you want them to eat right. Eat a balanced diet with little refined sugars, then exercise, moderate exercise, because we also know that vigorous exercise would also cause some of these things. So moderate exercise. And we said that if you have brisk walking 35 to 40 minutes, 3 to 4 times a week, that is adequate. Then moderate, in fact, little alcohol intake, no smoking, adequate rest. These are very important things. Then we have the medical and surgical options. So we have non-steroidal anti-inflammatory drugs for pain. They also help in reducing bleeding. Then hormonal therapy. This is used for everything, from bleeding to dysmenorrhea to PMS. So you have the oral contraceptive pills, the progestins. When giving the progestins, they're very good in controlling bleeding. In fact, for many patients that have menorrhagia, when you give them, they don't see their periods for months. But one of the drawback of it for it is that, especially for women who are still trying to conceive, they need to know that return to fertility can take time. It can take up to 22 months in some people. Then the levonorgestrel IUS system can also be used. Now we have the gonadotropin releasing hormone agonist. That's your Zoladex, Lupron. Can be used for things like endometriosis, both for the bleeding and the pain, adenomyosis, even for uterine fibroids. Can use it to shrink, either in preparation for surgery or waiting for menopause to happen. Then we have the dopamine agonists, bromocriptine and carbapenem, used in when we have hyperprolactinemia, either as alone or when there's a tumor, a pituitary adenoma. So you can use that. Then we have tranexamic acid for heavy bleeding, and then we should treat any underlying endocrine issues. Sorry, this is loading so slowly. Okay, so surgical options. So, of course, this depends on what the patient has. So, you can have a myomectomy for surgery, polypectomies, dilatation and curettage. Sometimes you might need to do, if there's a pituitary adenoma, for example, to take it out. If there's a thyroid swelling, a thyroidectomy. Sorry, excuse me. Then endometrial ablation can be done, but it's not suitable for those still desirous of childbearing, though we know that some people have gone ahead to conceive after doing it, but it's not suitable. And this can be done by radio frequency, freezing, or using heated fluid and microwave. Uterine artery embolization also can be done. And this helps reduce blood flow. Hysterectomy, which is um, especially in uterine bleeding and dysmenorrhea, this permanently will bring a solution. Then we have nerve destruction techniques. This is usually used for when there's severe pain. And this can either be done by the laparoscopic uterine nerve ablation or laparoscopic presacral neurectomy. So all the nerve fibers are destroyed. So in conclusion, menstrual disorders are common, but they're manageable. Accurate evaluation leads to effective treatment, and patient-centered care improves outcomes. These are my references. Thank you.
Thank you very much, Dr. Chichi, for the wonderful presentation. I guess we have all been informed. Can we send our questions to the Q&A chat box? Mrs. Inikpe, are you there? Okay, I see 30 participants are logged on. Send our questions or comments. If you want to make any comments, you can please indicate by raising of your hand, and then can unmute you for that. There's one question here for you, Dr. Chichi. As a biomedical scientist, I've noticed that some women who come in with menstrual issues like irregular cycles or heavy bleeding often have slightly abnormal TSH levels, even when they don't show obvious thyroid symptoms. From your experience, how much do these mild thyroid changes actually contribute to menstrual disorders? That's question one. Question two, do you think TSH should be checked more routinely when women present with cycle irregularities? So, Dr. Chichi, over to you.
Okay, let me start from the second question. Yes, I think that TSH should always be checked, because we know that some women have subclinical thyroid dysfunction. And even if it's subclinical, you can't see any obvious disorder, you can't see any obvious symptom for, they still have menstrual disorders. So I think it should be routine when a woman comes in with menstrual disorder to do a TSH. Well, that's what I do anyway. I do TSH normally because I found out that even some of them who don't show any symptoms, they have some thyroid dysfunction. So I think it should be. Then like I said, also, I found that many of them actually have thyroid function problems. And sometimes you just send them to the endocrinologist. So a little L-thyroxine here and everything normalizes. So it depends on what's, I think it should be routine for every woman who comes with abnormal bleeding. Yes.
Okay, thank you for the brilliant answer. There's another question here from, okay, the first question was from Deborah Odega. This question is from Tessie, and she says, if someone is having irregular periods after IVF procedures and successfully delivers through CS, what should be the next step?
I don't understand the question. Was it after she has delivered that she's still having the irregular cycles?
Well, I guess you can just if someone is having after IVF procedures, so it looks like she presented with this challenge after she has delivered through CS, right? So
Through CS.
irregular period
Okay.
after a successful IVF and she has delivered the baby through CS, then she
Okay.
presented with the irregular periods. What is her next step? So what are the options for her for
Okay.
treatment?
Okay. So if she has irregular cycles, she'll be evaluated fully to find out why. why is she having this irregular periods, and what kind of irregular periods does she have? If, for example, she's having hypomenorrhea, was there a problem during delivery? Did she get infected? Is the uterine lining affected? So it depends on what kind of irregular periods she's having. So she'll be fully investigated, and whatever the cause is, that will be sorted out. I can't say because there are too many types. Is it that she's having menorrhagia? Is it intermenstrual bleeding? So it is when she's fully evaluated, we'll know what is causing this irregular period. And that's when we can then offer a treatment.
Okay, thank you. Can you give us maybe one or two cases you've managed for any of the irregular periods? Maybe that will help to shed light or give the person an idea of what can happen.
Okay. So sometimes following cesarean section, depending on what has happened, some people can get infected afterwards, and this would affect the lining, and the person can have some form of uterine synechia. So bleeding will be less. And if you're not bleeding as much, most of the time and they find out it's because of uterine synechia, then we'll do hysteroscopy and do some adhesiolysis, and that would help. Now, if bleeding is heavier, then we need to find out why. Is there a medical condition? Is there an endocrine reason why she's having that? So that's why I said it depends on what we find, what the symptoms are. So I wish I knew exactly what the symptoms are, what the irregular bleeding is, and then I can then answer it better. So if she can tell us what kind.
Okay, Tessie, can you unmute? If not, Yejide, can you unmute her to explain? Because I see that she raised her hand so that she can speak more to the question. Tessie, can you unmute yourself?
Tessie, can please unmute yourself now? I promoted you to a panel so you can talk now.
All right, so please unmute yourself, Tessie, and then ask the questions. I mean, give more details.
I'm not sure she can hear us, or is it me that I can hear?
She's silent. So let me check. We don't have more questions. Does anyone want to make a comment? Okay, yes, we have one more question from Nsikak, Dr. Nsikak. What could be used as an initial pharmacological treatment for severe PMS? That's one aspect of the question. The second one is, and how early in the menstrual cycle should the treatment be started? Some PMS cases begin as early as ovulation. So what could be used as an initial pharmacological treatment for severe PMS, and how early should that be started? Thank you.
Okay, so one of the things I said was one of the first front lines would be oral contraceptive pills. They have been shown to help. And usually, you're also, for people who have severe dysmenorrhea or and bloating during PMS, it's good to start NSAIDs early. So usually I'll say start like 4 days before the anticipated periods. And usually that would help with pain, will help with bloating. And for the oral contraceptive pills, a patient should be on it from from the second day of their cycle and continue on it, and all the PMS symptoms are reduced. But then, if somebody has severe PMS and includes things like depression, anxiety, mood irritability, mood swings, then the SSRIs will do very well. That's the selective serotonin reuptake inhibitors. They help. Also, cognitive therapy helps a lot. I've had to send patients for therapy, and it has helped. You know, so these are things that we can do. Thank you.
All right, thank you so much for the answers. I hope that your questions have all been answered satisfactorily. Thank you. Yes, I see the thumbs up emoji. Thank you, Dr. Chichi. Mrs. Inikpi, are you there? Can we see and hear you before I ask the next question?
Okay, yeah, I'm very much here. Thank you, Dr. Chichi,
Oh,
for educating us on menstrual disorder as evaluation and treatment. Indeed, you've explored the evidence-based treatment options, and we are very grateful, ma'am. Okay, so as we all know, this session was recorded and will be available for playback on our AFRH website. I have a good news here. The second AFFS Federation Conference 2026, in collaboration with AFRH and IFFS, will be taking place live in Continental Hotel, formerly Sheraton Hotel in Abuja. And the theme is Fertility Frontiers, Global Innovation and Advances in Human Reproduction. And the date is on the 23rd to 25th of September 2026. So it's going to be a very big one. Do well by preparing to attend. Kindly follow AFRH on all our social media handle as displayed on the screen. For every information you look out for on AFRH, do well by going to our app. Via the app, you'll be able to get the latest information. So, and of course, via all our social media handles, all information will be available. On behalf of AFRH, I would like to appreciate everyone for taking out time to attend our bi-weekly webinar series from February to December 2025. It has been a fascinating journey so far, and of course, we've been exploring critical field of reproduction. A big thank you to all the presenters in the course of the year and everyone that took part, that participated as the audience. We really appreciate you, and this is our last edition in the year 2025. You'll do well by joining us again. Our next edition will be slated to take place March 2026. Yeah, until then, I remain Inikpe Uja Samuel. See you in the year 2026. Over to you, ma'am.
thank you, Mrs. Inikpi, for that very clear information we've gotten. The last question I see here is from Deborah again. And she said, for women trying to conceive or planning for an ART procedure who also have menstrual irregularities, is there an ideal TSH range you prefer before encouraging conception or starting fertility treatments? So what is the normal range for the THS for somebody who is starting their ART? Dr. Chichi. Hello, Dr. Chichi, are you still there? She's muted. Dr. Chichi, are you there?
Sorry, I didn't realize I was muted. I was speaking. I'm so sorry. Okay,
Oh,
so
bye.
normal CSH values are 0.5 to 5 um, milli international units per liter. So that's the normal range. So not if you're within that range, then that's fine. So and TSH is not the only thing you're looking at. You'll have to check for T3 levels and C4 levels too. So if they're normal, then it's okay. But if there's any deviation, then you should send to an endocrinologist. And because ideally, IVF should it's multidisciplinary. So when there's an endocrine problem, send to the endocrinologist, and then they'll help you. We have a patient now who has some thyroid issues. We've said sort yourself out. When you're euthyroid, then come back, because all these things affect your outcome. So once she's euthyroid, then we'll start treatment.
Okay,
Thank you
so much. The same Deborah has a contribution that she feels will be valuable to the team. And she said
Yes.
she believes that
Okay.
clinics should adopt a more holistic and comprehensive laboratory approach, a thorough panel that includes all relevant fertility-related tests would provide a clear prognostic picture and help reduce the risk of fertility, of recurrent IVF failure. So what do you have to say about this, Dr.
So
Chichi?
that's very important. That's why I said that we should work hand in hand with the endocrinologist, because one of the reasons why we might have failures is when we haven't evaluated properly. Like I said, thyroid function test is very important. You have to check prolactin, like all those things. Check all those hormones. Are they normal before starting? Because if they're not, then you're setting yourself up for failure. So we'll run all the tests and be sure that the patient is normal, all the endocrine functions are normal before you start treating. So even things as simple as checking sugar levels, because if somebody you do glycosylated hemoglobin and it's very high, for example, it's you're setting yourself up for failure. So you should check all those things, and then when it is normal, if it's not normal, then they should be sorted out before you try your IVF.
Thank you so much, Dr.
You're welcome. I can't hear anyone. And can you hear me?
Oh, okay. I think I was muted. I'm so sorry. Can you hear me
Okay.
now? Okay, I was just
Yes.
adding my voice to say that yes, fertility treatment is multidisciplinary approach. I heard you talk about cognitive therapy to assist those who have irregular menses. So yes, it's important that you involve everyone on the team so you can refer, you can get medical reports, you can get clearance before your IVF treatment. Thank you so much for the brilliant presentation, Dr. Chichi. I don't see any more questions on the Q&A, no. And we appreciate everyone that has made out time to be part of this year's webinar series. Thank you for giving of your substance to all the presenters. We appreciate AFRH for this gesture. We look forward to more in the year 2026 by God's grace, and we look forward to hosting you here in Abuja for the AFFS AFRH conference coming up in September. Thank you so much. Do have a good day to everyone. Good night.
Right.
All right. Bye-bye now.